So welcome to our annual ultrasound holiday Jeopardy. Should be a fun time. The first and second place will get prizes. So for those who do manage to win, please just let me know your emails after, and I will hook you up. So we're going to cover a variety of topics here. Try to do a smattering of things from throughout the year. But we obviously do think of multiple areas when it comes to critical care, not just echo. But we look at, vascular, abdominal, chest, tracheal, all kinds of stuff, really. But here is the board. So we have Texas sharpshooting. Okay. You guys know what Texas sharpshooting is? Yeah, kind of. It's actually Texas sharpshooting fallacy, which means if I shoot a hole in the wall and then circle it and say, look, I shot in the middle of that circle. A very common thing where, for example, when you're a medical student or resident, someone knows a patient has aortic stenosis and they ask you to examine the patient for aortic stenosis. So very common phenomenon. The next one's a view from here, just a different collection of different anatomical views, which I'll have to kind of decode. Lungs, okay, which is obviously lung ultrasound. Echoes of the past, just a smattering of different echoes you've seen here. And then finally, to tap or not to tap. So how this works is when we select a category, it's going to ask a question, okay? And there's actually like a Mentimeter. So we'll require your phones. I wanted to try this to see if we could try to maximize kind of interactivity, both in person and online, and also just makes kind of fun. It makes it a little more objective when people submit their answers. So it will require some texting, some tapping, but it should be a good time. But I'm going to randomly spin my pen here, and we'll just get started. Oh, okay. 200 or not. Okay, good. To tap or not to tap. So this patient with an abnormal chest X-ray, okay, and I don't want you to answer this. I want you to read the radiology report. Okay. And this whole category is like days of yore prior to ultrasound, where we have X-ray reports and then we just go for it with a strong arm and a 16-gauge needle. I'm going to ask you the question. Everybody good? Okay. We'll go to the question next. Okay, just scan the QR code. Okay, so we'll start this quiz. To tap or not to tap. Okay, we see a mix here. Let's see where this goes. So, tap away. There is a generous amount of anechoic space here. It's not a terribly high quality ultrasound, but you can see here, there's the diaphragm. Okay, there's the liver. There's the spine. Okay, along the bottom, although it's not terribly well seen periodically. The lung is there. This large anechoic space is the pleural effusion. Okay, so there is indeed a lot of fluid there. Yeah, it would be safe to tap this patient, although, it's hard to know based on the X-ray and based on the hedging of effusion versus consolidation. But this would be safe. Okay, let's move on kind of clockwise here to the next person. Okay, so we've already selected to tap. So what do you want to pick next? It's Josh, right? I think Josh.
Yeah.
What do you pick next?
Just a tap.
Tap 400. In this patient with an abnormal chest X-ray, is it safe to tap? Okay, now don't yell it out again. We're going to go here. So you can scan the QR code or just hit refresh. I'm not sure. Not to tap. Oh, okay. Well, that would be the right answer, not to tap, because that is just consolidation. Although, let me tell you, what if I told you someone attempted it? Yeah, because they did attempt it, which was obviously not a good idea, but it was attempted. But so yes, ultrasound is pretty obvious that we can see here, diaphragm, right? See the liver, and then there's consolidation. Okay, that's above there. So obviously it's not a large black space. We can't see the spine. So this is pretty emblematic of just dense consolidation. Have you guys seen this before?
Yeah.
Yeah, good. It's not new information, not new images, or new ideas. Okay. So he's gonna go up more to tap or not to tap. What do you think? Or do you want to move on? Okay. This patient post-liver transplant recovering on ward with severe respiratory failure. with right-sided opacity identified as enlarging effusion. That's actually the radiology opinion. This is enlarging effusion and they should tap it. That was the recommendation. You should be able to just hit refresh on your Menti and it should just come up. Let me know if it does or doesn't work. You should just refresh. Like if you guys are on the Menti, just go back to your web browser and hit refresh and it should just work. Yeah, it should just work like that. That's okay. Okay. Well, let me tell you, they were really, really excited on the ward, like really excited. And we had to kind of claw them back that maybe we should just, do another imaging study first. I'm sure given this is an ultrasound talk, there's some degree of bias, but interestingly, when radiologists do report findings like effusions, honestly, I would tell you that in a large portion of hospitals, people are they're ready to go and tap that, even if there's no ultrasound. Certainly in my internal medicine training, you'd be like, okay, well, the radiologist thinks it, therefore must be so. But we also had a lot more dry taps, which meant you were poking something you probably shouldn't. So. Okay, now this is a challenging one, okay? Now, I'm going to tell you, this was acquired in the right axilla, okay? And I mean right axilla, okay? This was acquired very high. Now, in this patient who's, had some liver surgery, what's happened? It's too high, okay. Oh, okay, hold on. So it's very high, and there wasn't enough fluid here. There's honestly, the volume of the right thorax was so small. We said, you know what, this is not going to work. Yeah, it's way too high. You'd be poking below the clavicle to get into the pleural space, and be a huge problem. Okay, now I got another question for you guys. Just hit refresh on your screens, and it should just work. And you're going to tell me what's going on here, because this is an important part of this presentation. Yes, it is. It's just 2 words. It's a free response. Okay, let's see who's got this. The correct answer is diaphragm paralysis. Yeah, so someone got it. Okay, so whoever said diaphragm paralysis, can you tell me why?
So when you look at it looks like it's not. You kind of see some movement of it, but it's more like it's just being plugged down on the thoracic wall as opposed to
Yeah, you have excursion, right? The diaphragm flattens like a pump. And what is it? And what is it doing here? Yeah, it's going the opposite way, right? So this is called paradoxical movement of the diaphragm. Okay, and this is classical when the diaphragm's injured. So, and if you actually you can sometimes actually even see the diaphragm on the side of the chest where it approximates chest wall, and you'll see the diaphragm doesn't thicken at all. Okay, in fact, it kind of moves inwards because a combination of respiratory muscles are maybe drawing a bit of negative intraocular pressure, pulling up a little bit. So pretty classical. And Josh and I had a case of this last week. I don't know if this guy had any further imaging at all. Yeah. Yeah, quite likely. He was like a blunt trauma to the left chest, I think. Yeah. He got extubated to BiPAP, right? Yeah. Yeah, I kind of figured as much. Okay. Well, anyways, this is a great case. And I wish I had a side-by-side here, but you would see how dramatic this is. This diaphragm should literally move downwards and flatten, okay? So it's quite bad. So that we're down, we've done the far right 3 columns. So do you just go 800? What do you think? Move on. 54-year-old male with cirrhosis, acute mixed respiratory failure in the ward. The radiologist indicates a large right-sided effusion. There is the pigtail. Okay. Pigtail's still draining as well, by the way. And it might look like it's in the abdomen, but it's not. Just because the diaphragm is semilunar. Okay, now we're gonna see if we're gonna tap this bad boy. Okay, oh look at that, 4 and 4, 50%. That's a true, coin flip. It's not. Okay, so what do we got here? So this effusion was actually massive. So there's the diaphragm. The diaphragm was actually quite flat. Okay, and large volume effusion of the diaphragm will actually flatten. It becomes basically at a mechanical disadvantage because that's simply the volume and pressure in the thorax. It's actually hard to see lung in here. Okay, it's there's just so much fluid there, and that tube was still in there. This is a transverse view, so the probe is turned 90 degrees. So this is a coronal view. Basically, move 90 degrees, you get a sagittal or almost like a half CT chest wall. That's the kind of the mediastinum / lower abdomen. You can see there's fluid below the diaphragm as well. Okay, so I like to get people to use both kind of views to assess pleural effusions because honestly, it gives you a much better appreciation for volume, but also where's the best place to stick a drain into or needle into. Okay, so this is a massive pleural effusion. And despite that drain being in place, I think the drain was partially out and not in an ideal place. So this can easily happen. So yeah, just a massive effusion basically. This was it on CT here. So we can measure effusion volume. This is done in the transverse orientation. So each centimeter is 200 mils. Okay, so this measures about 8 centimeters, let's say, but 1.6 liters. So if we typically will put someone supine so they're totally flat, and then I'll measure it from lung to chest wall. Supine. Yeah. That's probably going to be your more accurate measurement for volumetric assessment. Usually along the same level. So you try to, if it's like on this level, it's kind of there to there. But this is so large that, and you can argue it's just big all around. It's just so large that it's kind of like, well, sure you can measure it, but it's just big. In reality, it probably just needs to get drained. Simple as that. Okay, let's go to 1,000. Pardon me? Oh yeah. Yeah, especially with the recollection, like obviously it's producing fluid. 45-year-old male with kidney disease on dialysis, worsening findings on chest X-ray and is requiring more oxygen. So tap or not to tap? Okay, so 2 say tap and 6 say not to tap. It's fun seeing the vigilance levels change as we go out this presentation for this particular section. Okay, so this is the actual findings. Okay. So actually this is on the right side first. Okay, that's the left side. Left side trans. It's actually quite large on the left side, even greater than the right. So that's in the transverse view. You can see here I can't quite see that. I think it's around 5.4 centimeters, which is just over a liter. Basically very large on the left side and just less so on the right. So look back at the radiology report, left greater than right. So they were actually correct on this one, which is reassuring. But the rest maybe not so reassuring, is my point of this whole section. Okay, so we've done the whole tap or not to tap. What are we doing next? Echoes. We're doing echoes in the past, okay? So pick out your phone and just scan that QR code and it'll just get you on the presentation. What is this finding in a patient penetrating trauma? Just 2 words. No elaborate explanations required. Okay, correct tamponade. So someone here this is correct. There is a clot in here. Okay, there's certainly this patient had a long transport time and did get stabbed in the chest and had a clot there you can see. But the main point here at this level is really just pericardial tamponade. So this patient was pretty unstable and actually went to the OR kind of right away to investigate for to drain the effusion crater window and then also to make sure there wasn't a perforation, but there wasn't, and just bleeding. And so patient improved. The things we look at from like a clinical standpoint, tachycardia is a really important one typically. And then pulsus paradoxus, right? Now, in the setting of trauma, it's a bit different because you're both having bleeding and collapse. And so, the thing is that in the penetrating trauma scenario, I think most people are less like, what's the pulsus, right? Because it's penetrating trauma. There's clearly a problem if there's any blood in the pericardium. especially if it's penetrating trauma around the chest area. So I suppose that's kind of the main concern. So I definitely ignored criteria here entirely because I guess that wasn't the point. It's kind of like when you find blood in the abdomen with an EFAST, you're less like, well, how much blood? You know, it's like, well, but there is blood, and that's the point. Exactly. And plus, again, penetrating trauma. This is a bit of a different question. I recognize that, but it's just a good one to look over. But yeah, typically when we're looking for echo finds of tamponade, the things that you guys mentioned, like chamber collapse, is a really important feature of that. Okay, and you have a question too, Adam? No. Okay. But you will find that patients who are in tamponade, especially if they're low volume, like this patient here, had quite a bit of bleeding. Okay, was stabbed a few times in the chest, and so you actually are going to have a really hard time even seeing the right side of the heart because it's so low volume and because of the relative difference in pericardial versus ventricular pressure. So usually if you have really bad tamponade, especially if the volume is low, you'll just have like a really hard time seeing the right side of the heart. You'll mostly see the left. I don't know if Evan, you want to chime in at all with your perspective. I think I can't go back and change it, but I think hemopericardium with clot's probably the closest thing to. I think you get bonus points for that. What's that? 400? Let's go backwards. Okay. What heart rhythm is shown here? Okay, don't scream it out. Just scan that QR code and type it in. So you're gonna type it in. Okay, I'm not giving you answers here. You got to type it in. Oh yeah, so sorry.
I got it right, Adam.
Sorry, VF definitely counts. I have to put in suggestions. I just didn't think someone would put VF, but that's my own fault. VF does technically count. My apologies. But this is VF, okay, and you can see that there's the relations quite literally of the ventricular wall, right? It's not coordinated contraction. It's these fine movements across the myocardium. And you're probably like, why do I care about this when we have electrocardiograms? Why does this matter? Okay. Why does it matter? Do you guys know why it would matter? Why potentially matter? 100%. Yeah. So you can have cases where the ECG doesn't actually tell you it looks like VF. Okay. It could be really fine or could actually even look like PEA. And there are cases that are actually VF disguised as asystole. Okay. In fact, I was on my last year of fellowship in MAC. I was a patient of mine was being scanned by the echo tech, and I happened to walk in the room, and I saw the echo tech turn like pale all of a sudden, and I was like, "What's going on?" She's like, she points to it, and it's this. Okay, and you look at the monitor, and it hasn't changed yet. Okay, and then 5 seconds later, then it changes, and the patient arrests. So I've definitely had my experiences, but especially with using more TE during arrests, these kind of events are actually much easier to see because then you're not having to sneak in there, and get good windows between compressions. But there are clearly these cases where patients have VF where we're not detecting it as VF on cardiogram, which is pretty odd. And there's one study that actually showed upwards of it can be upwards of 10 to 15% of patients can have this problem, which it's a very odd problem. But when you think about cardiograms, it's actually not that surprising. Like we're just transitioning the chest for electrical signals. Obviously, it can be wrong, especially when they're low amplitude signals. Yeah. Okay, so next case. Patient had a stroke of uncertain etiology. Okay, now I'm going to start the quiz. So hit refresh on your phones. So what pathology here may have contributed? This is an apical 4 chamber. That's right atrium, right ventricle, left atrium, left ventricle. Okay, and that's bubbles being injected. Okay, so that's why it becomes echogenic. So there's something to do about this. Correct answer is right to left shunt. Okay. So a couple people said PFO. That's certainly quite likely. Okay, given why is that quite likely? Yeah. And how do we know that it's not just some massive intrapulmonary shunt? Anything here tell you that? Yeah. Yeah, if you look at reference manuals and textbooks and literature, you'll see anywhere, most people will say within 3 cardiac cycles should be kind of more cardiac, and then past 3 is intrapulmonary. But honestly, there's a lot of different ranges that are cited. But usually, if anything, for intrapulmonary, there should be a significant delay, or you need a few cycles to get the circulation to go through the lungs and back. So this is pretty early and pretty large volume. Okay. Now, so it is just right to left shunt. Okay. So this patient had an echo a year ago that was normal. So what do we think could have happened here potentially? It came pretty sick. Positive pressure is one explanation. Yep. PE. Yep. Now let's go with PE. So then they have PE. So then why did they stroke? Yeah, paradoxical embolism, right? And occasionally you'll actually see clot quite literally stuck in the PFO or ASD. Okay, but the reason why the answer isn't just necessarily PFO is it could be an ASD. You just don't know what it is. Okay. Yeah, no problem. Cheers. So we don't know exactly what it is, but it is a right to left shunt. Okay, so patient was actually hypoxic with the stroke with the PE, so which is unfortunate. Okay, we'll do echoes of the past here for 800. There's a lot going on. Okay, this is a Pearson long axis with color Doppler applied. They got a fast heart rate. I think it was around 120. This is the Pearson long axis, left ventricle, left atrium, outflow tract, aortic valve, RVOT, severe AR, severe MR, severe AS, or systolic anterior motion. Okay, so most people said severe AR. Okay, again, I'll highlight that because the heart rate's quite fast here, it's very hard for your eye to kind of track what's really going on, okay? But I'm going to slow it down here, okay? So this is likely systole here and diastole. There's diastole, systole, diastole. Okay, so this is clearly a diastolic problem, right? Yeah, high speed. Yeah, and there's this jet expansion with, like, you see this come back and flood the chamber. Okay, that happens in a jet, like very much like when you put your finger in front of a hose and the fluid speeds up, but then it kind of splays out, right? So that's that jet expansion in a regurgitant lesion. So this is actually pretty severe aortic regurg. So look up here. Okay, now color Doppler, red towards, blue away. Okay, so there's top right image there. You see blood flows in. That's the blue away. And then you see a red towards. Okay, but the color changes. That's the phenomenon of aliasing, which means you've exceeded the highest velocity in the retrograde direction. Okay. And that's towards the probe. So you're seeing what's called color mixing here. So this is quite severe aortic regurgitation. Okay, just the color signal alone, but there's a lot of problems with using color alone to assess how valves look. So other things we can use what's called continuous wave Doppler to look for essentially flow across the valve itself. Now here's an example. That's blood flowing away from the probe, and that's during systole where there's blood in the LVOT. Okay, but you can see this is zero, baseline 0, that's blood flowing away. Then you can see during diastole, rather than having no signal because the valve's competent, that's blood flowing away. Okay, and you see the density between these waveforms? They're pretty close, right? These are kind of isodense, which means that there's as much blood flowing forward as there is backwards, if that makes sense. Okay, and then we go to the abdominal aorta and we think, well, what happens to blood flow to the abdominal aorta? Okay, so if you remember the days of auscultation, they'd often ask, Adam remembers those days quite well, I think, quite fondly, I'm sure. I got much better at ornithology than I did auscultation during medical school, but that's just me. So that's forward flow, okay? And this is called pulse wave Doppler. We're sampling blood flow at this area in the aorta, Okay, take my word for it. It's kind of hard to see that that's the aorta there, but it is. Okay, that's blood flow away. That's the heart pumping blood through the aorta. And then this is diastole. Okay, and what's happening during diastole? There's some dropout here, but there is continuous signal. Okay, which is called holodiastolic flow reversal. During the entire period of diastole, blood is flowing in the opposite direction. Okay, that is consistent with severe aortic regurgitation. Okay, it's also one of the auscultatory findings you listen for is, is the flow holodiastolic? Okay, because you will have actually, in most patients, you will actually have some degree of flow reversal when you're during diastole, but typically you don't see it last the entire phase of diastole. So this is severe AR. Okay, this is why color Doppler is so challenging, because there's a number of factors that influence it, and by itself is usually kind of not enough unless you're really good and practiced at color Doppler. The rest of these things become really helpful. This is called spectral Doppler. We're looking at blood flow velocities. This is just a taste of kind of some more advanced stuff that we can do with it. And normally, my understanding is early. Yeah. Yeah, if you measure it, like even when you'll see an ultrasound where you'll see a tiny wink where blood just flowing backwards, only because of just the distribution of blood flow. If anyone wants to chime in, please do. Yeah, normally you'll have minimal signal up here. Okay. Oh. Okay.
Texas sharpshooting.
Okay. Texas sharpshooting for 600?
Yeah.
Let's do it. What is the name for this oscillatory finding consistent with these echo findings? Okay, so everybody here, just look at this echo. This is called M mode. This is on a short axis. Okay, this is short axis. And what and this is the anterior leaflet that's being M moded, and this is the posterior leaflet. Okay, it's in short axis, so basically we're looking to see how the valve kind of opens and closes. What is the name for the oscillatory finding consistent with these echo findings? This would be one of the most kind of representative phrase for Texas sharpshooting. Such a really interesting thing you can see in echo where the jet literally impinges on the anterior leaflet and kind of flutters it. See that fluttering there going on there? So of course, what is Austin Flint? Like, sure, it's fluttering, but what is it?
We typically get that flow from the ultrasound. The blood will go back and then hit the
Okay,
surface of the muscle.
and what does that do? Hits the valve, but does it cause anything?
Yeah.
Yeah. Exactly. Functional mitral stenosis. It's not, I don't think anyone actually develops severe mitral stenosis. And the thing is, Austin Flint really doesn't necessarily categorize aortic regurgitation as severe, as far as I know. It just frankly, it's probably more just like where the jet is directed. Because the way that aortic regurgitation works, the jet may not be directed that way, maybe directed in a number of ways. So anyways, this is just one of the ones where I had a talk to the medical students last week, and I was like, look at this. And it's just like, ooh, this is so neat and so nerdy. But it's deliciously nerdy. Anyways, what next? View from here? We did 600 Texas sharpshooting.
View 1,000.
The view for 1,000. Okay. The view and the body part. Left atrial appendage view. Oh, sorry. I should have got rid of the view at the end. Clearly, there was somebody who got it. I'm expecting that would probably be Evan. Really? Oh. And the next person would be...
It was Cowan.
It was Cowan. Oh, that makes sense. Good job, Cowan. Yeah, so what this is, basically this is transesophageal echo. Okay, and this is a very odd view here. What's happening is, so we're at 90 degrees, okay? Now, if you do an apical two-chamber view, in some patients you actually can see a left atrial appendage, but we're doing in reverse from the back, okay? This is left atrium here. It's atrial appendage. Okay, anyone know what this structure is here? Got a really funny kind of pseudonym.
The Coumadin Ridge,
The Coumadin Ridge. Why is it called the Coumadin Ridge?
because if you saw it on echo, you got put on Coumadin.
That's right. And what is it at? What's its actual name? It divides the atrial appendage view from the left upper pulmonary vein. Okay, so it's routinely seen all the time, but people used to see it. It used to be more prominent too in transthoracic echo, so you think it was a clot, but actually it's just a normal anatomical view. This appendage is actually quite big. Okay, and I want you to look closely. Like I want you to squint at this view and just pretend for a second that maybe it's not entirely black in that appendage, right? But there's something in that appendage. I'll also know that that appendage is quite generously sized, okay? So that tells you something about probably some degree of left atrial pressures and a bit of the risk of thrombus is because there is probably some stasis in that appendage. So this would be called the left atrial appendage view. So this is points to Sean. So yeah, this is the left atrial appendage. You see the mitral valve there, left ventricle. Okay, again, that Coumadin ridge, and there's some thrombus in there. Okay, so where are we going to next? Which one? Oh, actually, it's Sean. It's Cowan's choice because he won that one. Cowan, go ahead.
What was that one? That was view from here 200, right?
Yeah.
That we did? Okay, let's do
Was
view
it
from here
1,000?
400.
You've mirror 400?
Yeah.
Placed transverse at the suprasternal notch. Okay. This event. What is this event? Esophageal intubation. Okay, so what's happening here? This is again at the suprasternal notch. There's trachea. Okay, so see that white ridge there? That means it's an air tissue interface. That's seen at the lungs as well. But that's a trachea. Okay, and then usually actually esophagus is right here. Okay, and it can be hiding right behind. Sometimes easily seen, sometimes less easily seen. But watch as the balloon is inflated, the tube's advanced, cuff's inflated, you see a new trachea appear beside the old trachea. It's not a trachea, it's just a tube, obviously. But that's when you, so if you place the tube at the suprasternal notch, you can actually see a tube being advanced into the esophagus. Sometimes it's easy, sometimes it's hard to see. In fact, in courses where they teach this technique, they get people to swallow carbonated drinks. Yeah. Okay. It's neat, right? Okay. Any time for one last question here, then we'll go to the leaderboard. What do you think? Echoes of the past, 1,000? This sono-related song title. Hocus Pocus by Focus. Okay, here's the leaderboard. Okay. It's like Evan took it. Outstanding. And then Dr. Centipede. So if you guys can give me your emails, well, I have your email, Evan, and if Dr. Centipede cares to share their email, then please do, and I will send you something. Okay, well, thanks everybody for participating today. That was a fun time. I hope you guys all enjoyed yourselves as much as I did. I thought it was a lot of fun.